Welcome to this special LDI virtual seminar today. I'm David Grandy, Penn LDI's Director of Policy. We're excited about this event today. We have an important conversation this morning about one of the greatest challenges in American healthcare today, our long-term care system. And though there have been long-standing challenges, those challenges were more acutely visible during the pandemic. Long-term care is arguably the largest gap in our patchwork American healthcare system. More than 1.4 million individuals live in over 15,500 nursing homes across the United States. Almost everyone knows someone that has been or is in a nursing home, but few people want to end up in a nursing home. And nursing homes have long been neglected and underfunded, yet they provide care for some of the most vulnerable members of society. The last major attempt to reform nursing home care was spawned by a 1986 report from the Institute of Medicine, which followed decades of reports identifying inadequate care and abuse of nursing home residents. And that report's recommendations provided the basis for Congress to enact major reforms to nursing home regulations through the Nursing Home Reform Act in 1987. And this act led to some improvements in care. Yet more than 30 years later, we're still failing to protect nursing home residents or provide them with high quality care. The inadequacy of nursing homes and the failure to protect nursing home residents became highly visible during the COVID-19 pandemic, as hundreds of thousands of nursing home residents and staff died from the disease. So these events remind us that further reforms are sorely needed in nursing homes and also provided the impetus for an April report on nursing homes from the National Academies of Science and Medicine. So today we will dive into some high priority issues in US nursing homes and in long-term care more generally, focusing on what can be done to fix our biggest problems. And we do have a unique format today. We are first going to start with a conversation involving three distinguished researchers who all served on the panel from the National Academies. Following that conversation, we will be joined by Senator Bob Casey from our home state of Pennsylvania, who is chair of the Senate Special Committee on Aging, about how we can achieve policy change. And then we will hear from Rodney Whitlock, a veteran of Capitol Hill, that will share his views on a similar question: what will it take to move reform forward? So let me introduce our panelists. First, I will start with Mary Ercek. Mary is a senior fellow at LDI, senior scientist at the Department of Veterans Affairs, and professor at the University of Pennsylvania Schools of Nursing and Perelman School of Medicine. Dr. Ercek is a leading authority on nursing home care and end-of-life care. Next up, we have Jasmine Travers, is an assistant professor of nursing at NYU Rory Myers College of Nursing, where her research aims to improve health outcomes and reduce disparities in vulnerable older adults. Her ongoing research focuses on neighborhood disadvantage and nursing home outcomes and examines unmet needs and avoidable nursing home placements. And finally, we have Rachel Warner, Executive Director of LDI and the Eilers Professor of Healthcare Management and Economics and Professor of Medicine at Penn. Rachel is a health economist and general internist. Her research focuses on understanding the impact of healthcare payment and financing on the quality, organization, and delivery of care, with a particular focus on nursing homes. And as I mentioned, Drs. Ercek, Travers, and Warner all serve together along with 9 other experts on the National Academies of Science, Engineering, and Medicine Committee on the Quality of Care in Nursing Homes. So I am going to turn things over to Rachel to get us started for this event today.
Great, thank you, Dave. And I want to thank Mary and Jasmine for joining me in this conversation today. So I'm going to ask Mary and Jasmine to turn their cameras back on. And our goal here today is to have a conversation about the high-level recommendations that came out of the National Academies report. So as Dave said, Mary and Jasmine and I served together on that National Academies committee, which over a year and a half considered many of the crises in areas where reform is needed in nursing homes. It resulted in a report of over 600 pages that was released earlier this spring with many recommendations. And so today our goal is not to cover the waterfront of those recommendations, but to just have a conversation about what our highest priorities are and really speak on behalf of ourselves as experts in this field to talk about how we can really think about the problems in nursing homes and what we might do to reform them. So Mary, I'm gonna start with you. You have thought a lot about how to improve care delivery in nursing homes and what high quality care looks like in nursing homes. If you were to highlight one problem that we really need to address, what would that be?
Thank you, Rachel. In general, I would say there are many, but one important area is we need to get a handle on how we would evaluate whether or not good care was delivered. And to that end, we talked a lot about on the committee quality measurement. In nursing homes, we measure many quality indicators. And yet there's a glaring omission in all those outcomes and process measures, and that is the resident and the family voice. In most healthcare settings, hospitals, hospices, home care, there have been developed and publicly reported patient experience measures. And despite the fact that 3 measures of patient experience or resident experience have been developed for nursing homes, those have not been deployed on a national basis. There are 3 states that do their own patient experience measures, Ohio, Minnesota, and Maryland, but there's no way to assess care writ large across the entire system. And so and there are many reasons that have been given for this. There are resources necessary to contract with independent companies that would do these surveys. There's also a major issue in that most of the surveys are mailed out, or potential respondents are notified by phone or even over the internet to respond to the survey. And so it's post-discharge. In nursing homes, we have people living in nursing homes. And so that requires that someone go into that nursing home, someone who is comfortable talking with people who may have cognitive impairment, visual and hearing deficits, and interview them. Not only that, we need to make sure that that's done in a place where they can provide open and honest feedback. Okay, so if you're sitting in your room and the nurse or the nursing assistant walks into your room, that is obviously going to affect how you respond. So it's a hurdle, and yet 3 states have overcome this hurdle. So that's it's a major area. We, as you know, we broke off into subgroups, and I was on the quality measurement. This was the first and most easily, it was so easy to reach consensus around this recommendation that we really need to have a patient experience. The CMS recently called for proposed change and with areas for comment. And to their credit, they did call for the deployment of a measure called the core Q, which is, and they called for it in short stay patients. There are a couple of issues with the core Q. We called for the use of the consumer assessment of healthcare providers and systems. And there's a family of measures. Those are carefully developed using the highest standards of survey development and testing. In contrast, the core Q is developed largely by industry and is used, and it's more of a satisfaction measure. And so it doesn't really dig into the areas of care that we know are most important to residents and families. So while it's a step in the right direction that they call for a patient-focused measure, it falls short because it's a 3 or 4 item measure. People tend to give the highest ratings, and nursing homes use it as almost a marketing tool. So it's very much less useful for quality.
Yeah, so thank you for that overview. I think I just want to highlight that people live in nursing homes. It seems like one of the most important ways in which we might think about providing high quality care is what their experience of living in those nursing homes are. And it's much different than other healthcare settings like hospitals and outpatient settings where we have successfully implemented measures to get patients experience. And so I think the resident experience of care It seems like a really low bar to be able to measure and focus on improving nursing home care. Surprising it hasn't happened yet. I hope that's an area we can make progress in.
Yes.
Jasmine, I want to turn to you. It's hard to have a conversation about improving nursing home care without talking about the workforce in nursing homes. And so could you start by just painting us a picture of what the nursing home workforce looks like and the challenges that it faces?
Definitely. And one thing I'll start off by saying also, Rachel, is that the COVID pandemic has been the 9/11 moment for nursing homes. And one of the biggest challenges that I believe, just thinking about the workforce, is maintaining a sufficient staffing level. And the thing about the staffing levels within nursing homes is that staffing shortages that nursing homes have been reporting have been existent long before the pandemic. But one thing that we're seeing that's even more problematic is that these staffing shortages are increasing over the course of the pandemic. So for example, 21% of nursing homes reported staffing shortages in May of 2020. But now that number has increased to 28% of nursing homes reporting at least one staffing shortage. And just kind of to think about this a little bit more, there's a number of factors that make achieving sufficient staffing levels in nursing homes difficult. So first, I say the negative perception of nursing homes, and we have just been doing a poor job with kind of promoting nursing home work. People are not going to want to work in places that are not viewed favorably. And then thinking about the training of healthcare professionals starting way back when, and what we actually provide with regards to experiences, acute care versus long-term care. Then within nursing homes, there's unsupportive working conditions. So thinking about the high work demands and then just inadequate skills to be able to provide the care that you need to provide is an issue. And then poor pay and benefits. Nursing assistants, for example, do not make a livable wage. They make about, on average, $16 per hour. In many places, that is not sufficient to actually be able to secure the needs that they need to secure on a monthly basis. And then with regards to benefits, 20% of nursing assistants are uninsured. And then another issue that has been significant is the turnover rate among staff within nursing homes. And we hear a lot about clinical staff, so registered nurses, licensed practical nurses, and certified nursing assistants. But the turnover rate is high among the administrators as well within nursing homes. And we've seen research that shows that when this turnover among admins is high, that is associated with even higher turnover among the clinical staff. So for example, research shows that turnover among admins and top level executives to be 20%. And then for total nursing staff, so that's RNs, LPNs, CNAs, to be 128% on average. And then there's a number of other competing factors that nursing homes have to deal with, especially given the pandemic. So with regards to pay differentials, nursing homes pay less than acute care and ambulatory care settings. In other settings, workers can get better benefits, less demand, for example. And then there was better incentives to work in other areas, including not having to go into work as often in other settings when compared to nursing homes during the pandemic. And then I think finally, I would probably say that the pool is just not there. We have a greater demand for nursing home staff than we have supply. So that's something that we're going to need to work on as well.
And so that's, it was a great overview of the many challenges faced by the nursing home workforce. What would be your highest priorities in trying to address those challenges? Or your first highest priority? Let's start there.
My first highest priority. So we have to increase the numbers of staff. Nursing homes are struggling. And while there is some policy efforts to increase staffing, we need to really be just intentional about how we provide support to nursing homes. So it's not just increasing pay within the nursing home setting, which that's important. We have to change the environment of nursing homes. We have to make nursing homes a better place for staff to work. For example, we have to provide staff with the sufficient resources and supports and training that they need. And then we have to increase the bodies within nursing homes. So thinking about recruitment and retention, how do we increase those numbers? And then how do we retain those individuals? So at the current time, as we're trying to increase staff, nursing homes have become creative. So thinking about what other roles they have within their nursing homes that they can cross-train. So for example, a housekeeper being cross-trained to work as a nursing assistant, and then creating pathways. So within our report, we have, and you know, Rachel, we have put in just plans to assess what minimum staffing levels look like. And coincidentally, and thankfully, CMS through the Biden administration as well in connection with them has put out a request for information to receive information about what does this minimum staffing level number look like how do we kind of institute that, what's the best numbers, and then from there CMS will plan to actually report those numbers publicly through the Care Compare website so that people can actually say, all right, are nursing homes meeting quality levels when it comes to staffing? So really hold nursing homes accountable for staffing, holding them accountable for retaining staff and changing their nursing home environments, and then also providing funds that will help nursing homes be able to do so. One last thing that I'll say, Rachel, is we've talked about, what nursing homes are doing with the funds that they're receiving, and how can we better appropriate those funds to areas that are going to improve resident care and staffing. And there are a couple of states that have started to require nursing homes to appropriate funding towards resident care. But New York in particular has also required a percentage of those funds, such as Medicare, Medicaid funds, to be appropriated towards staffing. So that is something that we will look to see, how much staffing has improved now that we're actually earmarking funds towards staffing and a minimum number of funds, minimum percentage of funds.
And so just one sort of follow-up question. There are about staffing levels and minimum staffing standards. There are federal minimum staffing standards. Are those enforced and are they high enough?
No, they're not enforced. They're not enforced in the ways that they need to be enforced. And I would say they're not high enough, and we're not even meeting those numbers that are currently out. So with our recommendations, we really want to identify what are the appropriate numbers, and also in consideration of the case mix. So the complexity of the care needs of the residents is really also something that needs to take into consideration. And that's been very controversial of how do you actually put a minimum staffing level and not necessarily consider a number of other factors that exist within the nursing homes, so which is why CMS says, you know what, let's really get more information about how we can do this very intentionally.
Yeah, and those federal minimum staffing levels were based on information that was gathered decades ago when the level of complexity in nursing homes is really much different than what we see today. So wouldn't be at all surprising if we, through this information gathering, found that the nursing home staffing levels need to be much, much higher.
I agree.
Okay. Thank you, Jasmine. I want to just talk a little bit about the financing of nursing homes, which is another area that the National Academies tried to address in its report. And I want to call out the urgent issues related to financing and payment. And so just to set the stage, which most of our audience, I think, probably knows, but the nursing homes generally include two distinct populations of residents. There are long stay residents, which make up about 2/3 of the nursing home residents. Those people, when they're in a nursing home, their stays are predominantly paid by Medicaid. And so the Medicaid rates are quite low. And although people who are enrolled in Medicaid make up about 2/3 of nursing home population, the percentage of the revenue generated by Medicaid is much lower than that. It's less than half. And so not surprisingly, the average margin for nursing homes in this area is negative. It's about negative 2%. The other distinct population in nursing homes is the the short stay residents. And these are people who we sometimes refer to as post-acute care. sometimes we refer to their stays as in a skilled nursing facility, but these are nursing home stays that are focused on rehabilitation after a hospital discharge. It's just over 10% of nursing home residents who have their stays paid for post-acute care, and that is paid predominantly by traditional Medicare. And those rates are really quite high compared to the Medicaid rates. And it's a source of revenue that nursing homes have come to rely on. Medicare margins are really quite generous, resulting in the payment is generous, resulting in margins that are above 10%. And so this creates a lot of problems in the financing of nursing homes. It causes fragmentation of care where there's little incentive to coordinate care across payers and across providers for nursing home residents. It creates something that we refer to as cross-subsidization, or using the Medicare revenue to cover Medicaid shortfalls. And on the face of this, that may not sound like a problem, but it results in overuse of Medicare services, and the selection of patients who qualify for Medicare services over people who might be enrolled in Medicaid. It also results in inequitable care. So nursing homes that have a larger portion of care that's delivered to people who are enrolled in Medicaid have worse financial status. And we know that in those nursing homes are often located in historically marginalized communities, have lower staffing levels, have lower quality of care. And so this is a system that is really piecemeal in nature. It's not a system that any of us would have put together had we set out to create a rational system of providing long-term care. And it results in big gaps in care. And so I think one of the points that the report made that I believe is very important is that we can't achieve meaningful nursing home reform without the establishment of a federal long-term care benefit. And so instead of having a piecemeal approach to paying for nursing home care, I think we need a single federal agency to pay for nursing home care, not just for people who currently qualify for care through Medicaid or Medicare, but for all people who need long-term care, many of whom are currently shut out of the long-term care system. This is I think one of the most important, in my view, one of the most important recommendations we made. It's probably the hardest one. I don't know, many of the recommendations we made are hard, but this is among the hardest recommendations that we made. I think we are a long way politically from being able to implement a federal benefit for Medicare. There have been attempts made in the past, which hopefully we'll have a chance to talk about over the course of the next hour, including most recently the CLASS Act under the Affordable Care Act, which was ultimately not implemented. But it's hard to imagine reforming the nursing homes and delivery of care within nursing homes without reforming how we pay for and prioritize the payment of long-term care for nursing home residents. So that would be my highest priority. I want to quickly maybe go around the virtual room here one more time and think about maybe some other priorities that we might implement to address nursing home care. So Mary, I will turn it back to you and say, after measuring patient experience or resident experience of care and family experience of care, what would you do next?
I think in terms of, again, quality, we strove hard, I think, in this committee to balance what we heard from stakeholders and what we know already in nursing homes, that we need to hold nursing homes accountable. There are serious issues and they need to be, we need to reinforce that program of quality assurance, which basically, identifies and holds nursing homes to a minimal standard of care. That's what quality assurance is. And that's what the survey does. That's what some of our publicly reported outcomes do. But we also need to support nursing homes in improving the quality. Nobody wants to stay in a nursing home or have their loved one in a nursing home that is merely meets the minimal requirements, right? We want to all go to a very good nursing home. And how do we support people? How do we support nursing homes to do that? Quality improvement activities have been required in nursing homes for years. They're required in every healthcare setting. What we don't know in nursing homes is the best way to do that. Typically, it's been done through quality improvement organizations. The record on those, we don't have a lot of good data on whether or not that program works. There are individual programs that have been evaluated, a quality improvement program in Minnesota. I think the one in Missouri, in which the University of Missouri School of Nursing delivers the quality improvement activities, I think is a good model. But that's another area I think where we really struggle. How do we help nursing homes get better and better?
Yeah, that's a great question. I think it was a question during the pandemic that came up a lot. How can we better support nursing homes when we saw them really struggling to respond to the pandemic? The genesis of the SWAT team as well.
Yes.
Hopefully we don't have to rely on SWAT teams going forward, though. Jasmine, what about you?
For me, I would say my next priority would be training. Just kind of as we laid out, especially with the care for residents, nursing homes are complex. You know, managing nursing homes are complex. The care needs of residents are complex. So with that requires adequate and sufficient training for staff, which is very limited across nursing home personnel. So thinking about executive personnel, administrators, directors, to clinicians, to other personnel within the nursing home setting in areas such as finances, operations, geriatric syndromes, infection prevention and control, as well. So during the pandemic, many staff shared fears and concerns related to infection prevention and control efforts. So simple things like mask wearing, donning and doffing gowns, and hand washing was something that was lacking and very much a concern for staff to be able to carry out, and led to increases in infections among nursing home residents. And I think that problems with this is related to variations in training requirements across states, for one, and then just limited access to training, and then also just training that is actually affordable when thinking about different type of staff. So, for example, nursing assistants. So that's one thing I would say, Rachel, is the need for training. And then kind of just one thing I wanted to just kind of talk about as you were introducing another topic was just the staffing issues within nursing homes. Right now, nursing homes are really challenged with staffing in that they have to close beds and still work insufficiently without the number of staff that they need. So that's an additional problem when thinking about being able to provide care that residents need. And so with this whole conundrum of lack of training and lack of staff and being able to provide that quality of care that Mary was talking about.
Okay, that's great. Thank you. I think that we've seen that the challenges we face within a nursing home are really interrelated and connected to each other. And it's hard to address one problem without also addressing another problem. And so relatedly, I think that, my next priority would be, if we can't have a federal benefit to pay for long-term care, would be raising the Medicaid payment rates for nursing homes. And so, as I said, the Medicaid payment rates are commonly thought to be too low to cover the costs of delivering care. But it's an interesting problem in that we don't actually know, because we have no insight into what's happening within nursing homes, no transparency about how nursing homes are spending money. And so along with increasing Medicaid payment rates, we really need to think about how to increase the transparency of the finances of nursing homes. This is, increasingly, we have heard stories about nursing home owners seeking profits at the expense of providing care, sometimes by outsourcing goods and services to companies that either they own themselves or that they have a financial stake in. So in other words, they pay themselves for rent, for management, for nursing, for therapy, and they pay themselves at rates that are really much higher than what the market would bear. And so it's a way that some nursing homes have siphoned money off that could be used to pay for care, and instead are going to profits for the nursing home. Some work that was done by the Kaiser Family by Jordan Rowe at the Kaiser Family Foundation back in 2018 found that about 10% of nursing home expenditures go to these kinds of transactions. And so my last wish would be to increase the transparency we have around how nursing homes spend money. And I think we can't raise Medicaid rates without doing that. So I see that we've been joined by Senator Casey. Senator Casey, thank you so much for joining us.
Hey, Doctor, good to be with you. Thank you.
Yeah, so we will take that as a transition to the next part of our seminar. First, before I do that, I want to thank Jasmine and Mary for opening this seminar with us and having a conversation about the reform that is needed within nursing homes. So thank you so much.
Thank you.
So we are thrilled to be joined by Senator Casey. As I'm sure you all know, Senator Casey is a senior senator from Pennsylvania, first elected to the seat in 2006. Throughout his career, he's been a strong advocate for policies to better support seniors and individuals with disabilities. Senator Casey serves on two committees that deal closely with healthcare, the Senate Finance Committee and the Senate Health, Education, Labor, and Pension Committee, or the Health Committee. He's also chairman of the Special Committee on Aging, where his agenda has focused on policies that support seniors and individuals with disabilities. So Senator, thank you for joining us today for this conversation. As chair of the Senate Special Committee on Aging, you've been a national leader when it comes to thinking through some of our nation's challenges in supporting older adults with their increasing care needs. I wondered if we could start by just hearing from you about why you're so passionate about this area. What got you started in thinking in your dedication to trying to address this problem?
Well, I think when you have an interest in or a passion about an issue, I think there are multiple sources of that. And I think part of it starts with my parents and the family I grew up in, the respect that they always conveyed to everyone they met, but the regard and respect that they had for seniors, whether it was my mother's mother who lived in our house for a number of years, and which is what used to happen more often in previous generations, but when I was growing up, it was less common. But she lived with us, and I think we all learned a lot from getting to know her better as someone living in the house with you. But I think also for me, the foundation of this goes back to my first year as a public official. I was the Auditor General of Pennsylvania, and one of the issues that I inherited from the previous Auditor General was an ongoing national performance audit or series of performance audits across a number of states, including Pennsylvania, of long-term care. And when we got the results from that back, I was horrified, as I think people across our state were horrified, that emergency priority one, as they were called in those days, complaints in nursing homes were not being investigated, either at all or in a timely fashion. And that finding, I think, outraged me, and it outraged a lot of Pennsylvanians when we released the audit. So it started with that, but then we did a lot of follow-up work. It wasn't just condemnation and finger pointing. That's part of what you do when you do investigations and audits. But we wanted to broaden that into an array of public policy proposals. And that required me, as a public official, not to sit in my office, but to go around the state and to listen to people. And I'll tell you, when you get down to it, it's in some ways it crystallized in one conversation I had. This woman by the name of Shirley, and we asked if we could go with her to visit her husband in a nursing home in southeastern Pennsylvania. We sat down with her ahead of time I guess it was like a small diner, just saying, tell me about your husband and tell me what you hope we can accomplish today. And as she began to speak about her husband in this nursing home, she began to cry. And in that moment, I had just begun to understand what families are worried about. This woman who loved her husband so much and took care of him all those years now had to turn over that care to someone else, to those who were in charge of a nursing home. And for a variety of reasons, she didn't think he was getting the care that she could provide to him. So we have to be responsive to those needs and those concerns. And that means we've got to provide families not just one option, which for a lot of families works out just fine. The loved one is in a nursing home, they get good care, the family can come in and visit and in a sense hold the nursing home accountable by their presence there. But these families also should have another option, which is care in the home or in the community, home and community-based services, which I've spent so much time advocating for seniors and people with disabilities. They ought to have that option. And the Medicaid program ought to make that possible. For too many families, that is impossible, cannot happen. So the one option they have is care in a nursing home. And in some places, fortunately, it's a small percentage, maybe less than 5% of homes that have the most problems. But for a lot of families, that becomes a dark chapter in their lives. And we've got to make sure that that we not only do better oversight and improve the care in nursing homes, which is an ongoing battle that I know you've been waging for a long time, but also to provide more options. So I think that's kind of the foundation of my work.
So I want to turn in a moment to some legislative approaches to trying to address some of those challenges that you've laid out for us. Before we do that, I wonder if we could hear from you about how the thinking in how to address those challenges varies between Democrats and Republicans right now. And so I'm wondering what's in the Democratic playbook compared to what's in the Republican playbook in terms of policy, not in terms of politics. Like, where do we stand in terms of those two sides of the aisle?
Well, I think the fundamental difference, Doctor, is I'm not going to make a judgment about Republican senators generally, their commitment to long-term care. I have no doubt that they have loved ones that they care about and they have constituents they care about. But the problem we've had is how much in the way of funding are you willing to commit? In two ways, or I should say in two settings. One is how much in the way of funding are you willing to commit to better care in nursing homes and other long-term care settings, institutional settings, I'll call them. And that requires dollars. When I did the audit work in Pennsylvania, and I hit the state health department really hard, and they didn't like it. And the health secretary resigned because of the audit that we did. We didn't simply say, this is a problem. We made recommendations which were ultimately embraced, and that meant more dollars for better technology to track complaints. But to track complaints better, that meant hiring people and adding technology. It costs money, like anything else where you have to bring improvements, or in most cases. So the approach Republicans bring is, well, we don't need to spend more money on that kind of better oversight. We need just to improve it somehow. I just have a fundamental disagreement with that. When it comes to the funding generally, whether it's long-term care generally or the expansion of the options for families, which I believe they should have in home and community-based services, that's also a funding question. The Medicaid dollars have to go up, and not just up by a few billion or even tens of billions. It's got to be a lot more than that. We arrived at the point last year where we had, and obviously we didn't get Build Back Better done, but we had 50 votes to dedicate $150 billion of new money to home and community-based services. And I still think there's overwhelming support. But those 50 votes for the $150 billion were all Democrats. We can't get Republicans in the Senate at least, or the House, to embrace the kind of investment we need, not just to improve the existing options for families in nursing homes, long-term care settings generally, but for home and community-based services. So it's a gulf in terms of bringing together the sides on funding. And for some, look, in a lot of Republican circles in the House and the Senate, it's not just that they don't want to add new money, is that they have proposed in budget after budget after budget, especially during the former president's term of office, cuts to Medicaid that would be equivalent to cutting Medicaid by $50 billion or more a year for each of 10 years. That's what their budget proposals were. So they, as a party in Washington, this is my view, and some may not like hearing this, but in my view, the Republican Party in Washington is generally hostile to Medicaid. They want to reduce the Medicaid allocations that are currently there. We not only want to fight them on that and stop them, we want to increase it.
Okay. And so let's talk about some reforms that we might think about in nursing homes. So nursing homes are a key part of our long-term care system, though, as you pointed out, not the only part of our long-term care system.
Right.
We know that there's an urgent need to improve the quality and exercise better oversight. And so you've been an advocate of exercising better oversight, particularly over what are known as the special focus facilities. Introduced a bill last year with Senator Toomey called the Nursing Home Modernization Act, and then more recently, sent a letter to Medicare asking to improve the care of, asking to improve care in nursing homes with a history of serious quality issues. So at a high level, I wonder if you could tell us first what the concern is and then what solutions that you've proposed.
Well, a couple of concerns. When you get to that one particular, when you focus on that one particular program, the special focus facility program, and the nature of it, where you have participant facilities and so-called candidate facilities, the nature of it is such that the program is not covering enough of problems or enough of facilities that have demonstrated a record of poor performance. So the goals of the program are worthy, but they're just not covering the hundreds and hundreds of facilities that should be covered and be the subject of that special focus. So Senator Toomey, and I want to commend him for working with me on this, first of all, to expose some of these problems and pushing CMS to provide, Center on Medicaid Services, to provide more information, but also to be willing to have a bipartisan bill. Now, this is not a funding bill, and that divide is still there. But in this case, we introduced legislation to make sure that you can cover all of the programs that should be the focus of, or should be the subject of special focus. So it's Senate Bill 782, the Nursing Home Reform Modernization Act, to expand the program to ensure that all of those poor performing facilities are covered, and also to provide technical assistance. So that's the right step. We're hoping we can get that done because, as you know, this is not an area where there's a lot of bipartisan support. So that's one thing we can do. But beyond that, I think we have to do a lot more when it comes to nursing homes more broadly. There's no question that staffing is a huge issue, both principally in terms of the staffing ratios, but also staffing turnover. I mean, it's just a fact. All the evidence is irrefutable on this, that if you have high turnover, you're going to have bad care. There's just no escaping that. And you know this better than I do with all the work you've done. And so you have to create conditions or incentives that lowers that staff turnover. And I remember when I was on the road way back in the 90s, going to these facilities in Pennsylvania, that was one of the first questions I asked: what is your turnover rate? And most of the places we went, the turnover rate was 50% or more. So we have to take steps to reduce turnover, and also to make sure that staff to resident ratio is within a range that would ensure better care. So in addition to the bill I have with Senator Toomey, Senator Wyden, the chairman of the Finance Committee, and I have worked on the Nursing Home Improvement and Accountability Act, which we introduced last year. And we hope to get at least portions of that enacted into law when we get to the broader issue of long-term care by way of legislating through the Finance Committee. But it's essential that we focus on these basic issues in long-term care, issues that I know you and others have worked on for years.
And so maybe I just can follow up on that and ask what you see as the most logical next steps in terms of focusing on staffing, reducing turnover, and even increasing staffing levels in nursing homes, because it's a challenge that we see across the country in nursing homes, not just in Pennsylvania.
Yeah, part of it is that I think we need to at least get a baseline, and that's why our legislation would require that HHS would conduct a study on staffing within 3 years to get first of all, to get a baseline of information upon which we can build some reforms. We'd also require that the secretary use the findings from the report to set minimum staffing requirements. And this has been litigated. I've been litigated in a legislative sense at the state level. But I think it has to be more the subject of federal attention, both from the department as well as Congress. And I think should compel us to lead to appropriation, not just examining the problem, pointing it out and setting minimum staffing requirements, but also to focus on federal resources. Part of that, of course, is the workforce. You got to lift up these workers, and that means wages. That's why we talk about the other end of this, the home and community-based services part of this effort. You've got to give workers the opportunity to be paid a higher wage. Sometimes the wage in institutional or nursing homes is a little higher because the workers are represented by a union. That may be the only reason why their wages are higher. But in the long term or the home and community-based context, the workers doing that heroic, noble work of providing care in the home or in the community, they're getting paid $12 an hour. We can't say that as the most powerful country in the world that we really care about seniors. We really care about people with disabilities. If the people providing that care are making $12 an hour, that's an insult, not just to the worker and the good work that they do every day, but it's an insult to all of us when we say that we're going to build a better long-term care system and people doing the work are paid such a low wage. So the workforce has to be elevated and their pay has to be elevated and their benefits have to be elevated. If we're going to have the kind of professional staffing that will reduce the turnover that I made reference to earlier. So as you know, Doctor, there's so much more work that has to do. And I didn't even get to infection control and so many other protocols that have to be in place that horrifically we learned so much about in the pandemic, where we had more than 200,000 residents and staff in nursing homes die for a number of reasons. But one of the reasons was lack of infection control and lack of protocols in the middle of a pandemic.
Going back to the topic of lifting up the workforce and trying to better support the workforce in long-term care, and thinking more broadly, not just in nursing homes, but for home and community-based supports, so across the spectrum of long-term care. Maybe you could tell us a little bit about your Better Care, Better Job Act, which was introduced last year, which in part addresses the home-based workforce.
Yeah, I mean, we're trying to do a couple of things with this, and I would note for the record that, again, this legislation, the Better Care, Better Jobs Act, had 40 United States senators sign on to the bill. Unfortunately, all 40 were Democrats. We need to get Republicans to embrace this idea generally that we have to provide more options for families in the home or in the community. And it's obviously families that have a loved one who's a senior and needs that kind of quality care, but also a loved one with a disability. This has been a goal of the disability community for 50 years. And it's about time we made progress on it. But embracing the challenge isn't enough. You have to be willing to vote for the money. And as I said, we had agreement to get a huge investment of $150 billion over 10 years to begin to attack this problem and invest in families. But this policy and this bill would lead to what the name of the bill points to: better care for seniors and people with disabilities, because they can get that care in their home where most would prefer to get that care, whether they're a senior or a person with a disability. Better jobs for those who are doing this work, and better support for family caregivers. I mean, that's part of the equation here. We've got tens of millions of Americans who are providing care to a loved one out of an act of love, but they're leaving the job they have. It's not, most of the people doing this job weren't trained to be long-term care professionals or direct support workers trained in the skill and the in the care that requires. But we're providing care for a loved one at home, leaving the job, leaving the workforce. Most of them, of course, are women. It's one of the reasons a lot of women haven't gotten back to the workforce in the grip of the pandemic, and still as we look at these issues today. So making sure that we're focused on all aspects of this problem to lift up the workforce, which are also mostly women and mostly women of color, being paid $12 an hour with no opportunity to join a union, no opportunity for higher pay and investment. And it's also, of course, about providing better care for seniors and people with disabilities. And that's why this movement, which started not just years ago, but decades ago, has come to the point where we not only have a bill, but we have the result of a movement over many years to improve the care in these settings and to give families the options to have the care in the setting that they have a right to expect.
So you brought up what we refer to as caregivers, family or friends or loved ones who provide informal care to people either in institutional settings or at home, usually unpaid. It's a tremendous burden on, as you said, mostly women, and has financial implications, health implications, and other implications for caregivers. Some people I've talked to inside the Beltway say that providing more support for caregivers might be one place that we can expect to find bipartisan support for. Is that true? And what kind of progress can we expect to see in providing more support for caregivers?
Well, Doctor, I hope it can be, and I hope it can be the subject of bipartisan support, even if we don't reach the goals that I want to reach more broadly on long-term care and more particularly with regard to home and community-based services. But I hope that we could get more support for family caregivers, and part of that is just the basic compensation that's available, not only to the direct care workforce who are doing this work as a matter of as a professional and as someone dedicating their life, their career to this, but also for those who are doing it on a temporary basis, maybe for a couple of months or longer than that. But it does get back to that basic issue of compensation. We can't just ask family members over and over again, year after year, to just leave their job, leave the job that they have, leave the career that they have, provide the care and not get much help. And so it does get back to that basic issue of the resources available to help these families. And this isn't just a few million families. By some estimates, it's more than 50 million Americans doing this work. Most of them, as I said, are women.
Yep. So we just have 2 minutes left. I want to just wrap up by asking you about what we should expect next more generally. So aging in America doesn't feel like a partisan issue, yet we're living in this incredibly partisan time. The support for aging in America feels like an urgent issue to many of us, with the aging of the baby boomers and the crumbling of the infrastructure of the long-term care system. So I'm wondering if you could just speak to that, given this landscape and given the partisanship that we see, what is really possible and what can we really expect to see moving forward in the coming months and even years?
Well, I'll start by making reference to an issue that's on the minds of every American. Might be the most consequential issue for most Americans right now, and that's inflation. We are in an inflationary economy, and if you're a legislator, you can't just acknowledge it and admit that we have a problem. That's not enough. You have to do something about it. And I think legislators in both parties have to be willing to support policies that will get costs down for Americans. Now, look, I think my party, including myself, took steps in the last couple of years, especially in 2021, by passing the American Rescue Plan to get costs down for families. That $1,400 check that went to so many millions of Americans, tens of millions, and also the investment we made in the child tax credit, which gave more than right around $450 a family for most or for half of the year in 2021, reducing child poverty by 40%. You know what they're using that money for? Food, groceries, gasoline, rent, basic expenses that were already rising in price. But one of the rising costs in American life over a generation, not just in 21 or 22, is the cost of care. Families paying more and more and more for care, and the system overall having to pay more for care. We should invest in strategies that help families get those costs down. That's why all the things we talked about here today are ways to get the cost of care down for families and also get the cost of care down for government. We can pay $90 per person for institutional care. That's the cost of it now. Or we can shift more of our attention and resources to providing, or I should say additional resources, to providing opportunities for care in the home or the community. The cost of that care is about $26,000 per person. So you can pay the 90 per person or the 26,000 per person. I think most people would choose the latter. So this has direct relevance, not just to the allegiance we pay to older Americans who have given us so much, given us life and love and contribution and did so much for all of us, but it also has direct relevance to inflation. The cost of care has been skyrocketing for families and for government, and we've got to get those costs down. So this is, I think, this is a mission, providing better care for older Americans, getting those costs down for families especially. This is a mission worthy of a great country. And if we're going to call ourselves a great country, we got to earn it. One of the ways you got to earn it is to invest in our families, to invest in seniors and provide more choices and better care.
Well, thank you for joining us today, Senator Casey. It's been terrific to talk to you. I'm glad that you were able to take time out of your schedule to join us today. And thank you for the work that you do to advance the care for aging in this country.
Well, Doctor, right back at you. Thank you for your work and your scholarship and those that are joining us today, because that kind of advocacy, the kind of scholarship and research and work that you've done over many years is helping to inform and move us in the right direction. So thanks for your work as well.
Thank you. So we are now going to welcome Rodney Whitlock to join us to close out this conversation. Rodney is an accomplished healthcare executive with more than 20 years of experience on Capitol Hill, where he specialized in rural health, the healthcare safety net, and disability policy. He previously worked as a healthcare advisor and as a policy director for the Senate Finance Committee, Chairman Chuck Grassley, serving as the lead Republican staffer for Medicaid legislation from 2005 to 2010, and continued to serve Senator Grassley on all health-related issues through 2015. He helped to staff Senate Republicans on prominent legislation such as the Deficit Reduction Act of 2005, the Tax Relief and Healthcare Act of 2006, the CHIP Reauthorization Act of 2007, 2009, and the Affordable Care Act. He is currently a consultant with McDermott Plus Consulting. So Rodney, thank you for joining us today.
Thank you for having me, Rachel.
We are very happy to have you join us and provide some reflections on what you heard the presentations earlier today from my colleagues, Jasmine Travers and Mary Arisick, and also the perspective brought up by Senator Casey. So I thought maybe we could start by just hearing from you. What does success look like in long-term care reform in your view?
I'm going to take the easy way out and right now say, you know what? I would describe us as having been successful already. Cannot say enough about the effort that Senator Casey and his team has put in the last 18 months to take this issue from, footnote, minor, I'm sorry, what does this have to do with Medicare? That we are now in a space where we're competitive with those issues. And competitive mean competing for issue space, competing for dollars. I don't know how Build Back Better or Build Back Good Enough or Build Back Better than Canada, don't know how it's going to turn out. But I know that we're on the front page because of it. And so we're winning now. We have to keep at it.
And so what does keeping at it look like? How do we do that?
Advocacy. It is in Washington, listen, the joke, I'm in Washington, you guys are in America. Uh, that folks in DC need to constantly hear. And the profile of the issue, and that is caring for people at home, providing them the services and supports they need to meet what they need to be able to function, both those who are trying to work their way into the workforce versus those who are in later life stages, whatever the point is. That it's that constant advocacy that DC needs to hear, and particularly it needs to hear how difficult this space has become, and that's why the support is needed. Work like what Senator Casey has been constructing needs to be part of it. That we can't just say, oh, and then there's LTSS, HCBS. Well, I know some letters, I can use that in a cocktail party, but actually taking on the issues and addressing them in positive ways moving forward.
So you worked in Congress for a very long time, as I outlined in the introduction, but now have the benefit, or I've always had the benefit of not being an elected official. And so I'm wondering if you could reflect on why the advocacy that you're describing hasn't been enough, why Senator Casey described the challenges he has faced in trying to get meaningful reform through Congress, the partisanship that we face. What is it going to take to really, what is a practical fix that we can look towards?
That's tough. So listen, acute wins every day. Everybody's afraid of acute care. Everybody is always focused on acute care. Right now, what are you thinking about? My knee hurts. Do I need, knee replacement surgery? You're not having hey, you know what? In 15 years, I might need LTSS. It is that it's out there in the future. And the other thing is, let's face it, we are uniquely American in so many ways, some wonderful, some horrible. But one of our uniquely American things about us as it relates to LTSS is we have this whole national perspective that at the end of it, I'm going to pass away in my bed, surrounded by my family with angelic music all around. And I'll never have been in a hospice. I've never done time in an LTSS, an inpatient. I've never needed HCBS. I've never been in an IRF. I've never had significant acute episodes. Nope. I'll just go whenever I want, as I want. It doesn't work that way. And so we don't think about it. We don't prioritize it. But the more and more that we have a generation of people, the bolus of the baby boom starting to hit there, my parents, my grandparents, that we're going to actually have to start addressing it, because that myth that we have in the beauty of, how we want it to go, it's not real. And it's actually more difficult. It's more challenging, and it requires support. And we're going to have to start talking about how we pay for the support, because we're next.
So let me ask you the same question that I asked Senator Casey, which you were listening in the background. And I asked about, in terms of addressing these challenges that you're describing, how do you see the policy approaches that the Democrats and the Republicans are proposing as being different? And so again, what does the Democratic playbook look like here? What does the Republican playbook look like in terms of policy, not in terms of politics?
Listen, I think the Democratic playbook is what Senator Casey brings to the table. It's definitely flushing some resources into the system. That's not a bad idea by any stretch of the imagination. I think from the Republican side, listen, Republicans are focused on a very important number, and the Congressional Budget Office put it out yesterday, which is our debt service is going to rise to 12%. When if our economy is growing at max a 4%, and Larry Summers, who is a Democrat, said that CBO was outrageous in their optimism, hey, we got a problem. And so you have to at least respect people who want to say, let's be thoughtful in how we go about it. I think Republicans, my personal opinion, Republicans already have a model. They've already done it. It's called Part D, the drug benefit. And I think it's working towards solutions in which you're trying to combine public resources, private resources, and the resources of the individual to create the mechanism that gets you to providing a more systemic approach to HCBS, to LTSS than we do now, which is, hey, are you near death and broke? We're here to help, which is basically what the Medicaid system is.
So the last real progress in trying to have a systemic approach to supporting LTSS, I think, was the Class Act. So over a decade ago, under the Affordable Care Act. And as I said earlier on in this seminar, the Class Act did not get enacted ultimately. So why did the Class Act fail?
My dear friend Connie Garner is a primary staff author of that document, and the near death and broke is a quote from her that I stole.
Connie Gardner was a staff assistant to the late Senator Kennedy.
Ted Kennedy, yeah, legend here in DC. I think Connie and others who look at that will, I think, openly admit that there were challenges with the Class Act in terms of its structure, and that you have to listen. I'm a believer in this. I may be unique in this, but at least this is something I strongly believe, is that trying to create structures that address aged and disabled simultaneously under one structure is fundamentally problematic, because the differences in what you're trying to provide, the benefits you're trying to structure. Class, I think, was trying to do too much of, hey, let's see if we can shove it all under one roof. I think if you approach it separately and realize that the amount of time you're looking at providing LTSS for somebody who is over 65 and under 65, particularly under 65 disabled who are trying to function in the community, wholly different animal than what you're talking about for seniors. If you look at structuring benefits to meet needs, you're going to be closer there. I think ultimately that Class, for all of the good intention, the challenge was that it was still trying to look at both simultaneously.
And so is it, just to extrapolate from what you're saying, if there were a bill that focused on support for the aging Americans, but did not include disabled, is that something there would be an appetite for? And is that something, that would cost potentially money if the CBO were to score it? What would the support for that look like? What would that look like?
So first of all, I wouldn't necessarily say it's an or thing, that we only can do one or the other. It's just we can do both. We just need to consider them separately. I mean, I think thinking about it in terms of, what program better addresses which population. The Medicare program already covers acute needs for seniors, and that having an attachment between the acute and LTSS ultimate need in seniors makes a lot of sense. Medicare. The Medicaid program predominantly covers individuals who are disabled, and both through their acute needs and for their LTSS needs. I mean, the split is obvious there if you step back and are willing to go there. The problem is we have this nattering little problem of dual eligibles, that we made a decision that at some point to say that if your parent became eligible or you reached a certain work quarters, that your Medicaid acute benefits not good enough for you anymore. So now we've got to make you dually eligible, and split into an uncoordinated program that don't talk to each other and don't have the same goals. You get some in Medicare and some in Medicaid. It's being willing to step back from fundamentally confounding approaches and say, what's a more consistent approach? And you can do that for both, not an either or.
Okay.
Stunned you into silence. I love that part.
I was pondering that answer. Let me move to talking about some other issues related to long-term care. And so you and I had talked previously about what high-quality nursing home care might look like. I wonder if you could share your vision for high-quality nursing home.
I think the first thing we need to do is move in more of the direction of coming up with a common understanding of what high quality is. This is controversial, and I'll say it because I don't work for anybody anymore, so I'm not afraid. Listen, we have acute standards. We have expectations on the acute care side of what we expect. Too many providers on the LTSS HCBS side, a day when something doesn't go catastrophically wrong is a good day. The minimum standard, what we expect, is very different. Again, the joke I use when I teach this stuff, right? There's always a standard on the acute medical side. I mean, at one point in time, we had a president get pneumonia, and everybody looked at him and said, "Damn, Bill looks sick. Let's get the leeches." And that seemed appropriate. William Henry Harrison. And we don't have a strong enough set of minimum standards of what our expectations are, and we don't pay enough to be able to make sure we meet those. And so too many providers, their standard is getting through the day without something going horribly wrong. That's not acceptable. You wouldn't expect it at your pediatrician, a hospital, your dermatologist, no place. But we do that every day in LTSS, and that's wrong.
How would you address the challenges that we've heard about today related to the workforce in nursing homes and in LTSS?
Yeah, on the workforce side, we in the HCBS LTSS space, those of us who care about it, those of us who work on it, need to make sure that we are fighting like crazy the next couple of years, because workforce is a universal healthcare issue right now. People are seeing that hit every sector of the workforce. Our problem is we can't see Congress and administrations working in directions towards creating incentives for higher level needs in the workforce and skip DSPs, for example, direct service providers, in ways that people who might be thinking about, I can play in the direct service provider space, start going up, but I'll be an LPN, or I'll be an RN, or maybe I'll be a PA, and start to work their way up the ladder, finding us in a space where there are less and less people there. This is coming. What we have to do is make sure we're fighting to say, we need to make sure that we are right sizing the policy to make sure there's development of workforce in this space. Something we have to be very careful with.
Mm-hmm. And do you think that the long-term devaluation of the workforce in LTSS and long-term care may play a role in the lack of powerful advocacy in this area and in the lack of progress in this area?
You mean the part where people can get paid more to be a greeter at Walmart than a DSP? Yeah, that does it. I mean, Rachel, it's that you can't. The folks who stick, they are great advocates. They need more friends, and that's our problem in advocacy, and the problem where we have people beat down, and the challenge in the space. Listen, this is not a fun space to work. It's hard, and it takes special people to be here. It takes special people to provide services to the folks who need LTSS, HCBS, no question. But we need to do more things to develop that. We need to use more incentives. Here's a simple one here. Let states have additional Medicaid match to have pathways at community and technical colleges towards more work in this space. And set quality standards, or set minimum standards of what you expect somebody to be able to do, but throw some Medicaid dollars at that. Because you want to find ways to build workforce, because you need to treat people.
Mm-hmm. So, we're coming up on the end of our time here together. I think, as we've had this conversation, you and I have had this conversation today, it seems like a lot of the potential solutions for long-term care reform involve more money. So where does that money come from?
It's a bit of a zero-sum game, but we also have to remember the concept of investment. One of the challenges we face dealing with the Congressional Budget Office is they don't deal well with downstream effects. In other words, do investment have returns in healthcare? It's not one of the things in the long time I've been here, as you've well established, I'm old. The Congressional Budget Office doesn't really say, if you invest here, down the road you will save here. It's not one of the things they're very strong at. They rarely give that, and they've got their reasons to do that. What it takes is the gumption of a Congress to say, we're making these investments because we know they have returns. You can criticize it one way or the other. You can support it, you can be against it, but it is fair to say Senator Casey and the effort they're making is to say, we're making this investment because we believe it has returns. It takes more people willing to get there, but it's hard in the current environment.
And so is that an area we're going to see bipartisan support for, you think?
I think that Republicans aren't anti-LTSS HCBS. They're not anti-caring for people. They're worrying about that 12% number I threw at you. Yeah. And what we have to do is get people to the point that you are willing to sit down and try to be creative in a place where it's not really easy to sit down and try to be creative. That's the challenge. But I keep hope alive, and that's why I'm still here.
All right. Well, I think that is a hopeful note to end on. So, Rodney, thank you so much for joining us today. Thanks to all of the panelists who are with us today. It's been a really terrific conversation. This is an area that I feel very passionate about. I hope that some of the potential solutions we've talked about today are solutions that we'll see in the future, and that we are, at a consequential time where I hope that we begin to see more investment in long-term care and more solutions that will solve the problems that we face in long-term care. So thanks everybody for joining us, and enjoy the rest of your day.